5-year-old, 2 months boy. This is his third hospitalization, presented with rashes since the 6th, so 1 week. Maculopapular rash started from the back to the abdomen, to the neck, to the lower limb, and then the upper limb, and then face associated with itchiness. And then he had fever for 1 week since the 6th as well. Highest temperature 39.6 degrees Celsius, subsided after giving PCM, associated with chills and rigor. And then he had cough also for 1 week since the 6th, dry cough. Vomiting for 5 days since the 8th, 3 episodes, small amount, food content, non-bilious, no blood, non-projectile. Bilateral eye redness for the past 4 days since the 9th. Complaints of eye pain, sudden in onset, localized in nature, no radiation, no exacerbating or relieving factors, pain score of 5, no eye discharge. Loose stool for the past 4 days since the 9th, 3 episodes, Bristol 6 to 7, no mucus and no blood. Joint pain for the past 4 days since the 9th. Knee joint, elbow joint, wrist pain, all sudden in nature, localized, no radiation. Pain felt during rest and also aggravated upon movement, no relieving factors, pain score of 7. Okay, past history, just recovered from chickenpox. It's from the 25th to the 29th. Given PCM and was just quarantined at home. This is patient's third hospitalization. First hospitalization was admitted after birth for meconium aspiration syndrome. Stayed in hospital for 5 days, given antibiotic augmentin, and then discharged. Second hospitalization at 1 year 11 months, admitted due to RSV pneumonia. Admitted for 6 days. Admitted first 2 days in 8 PA under nasal pump oxygen, then recorded off-team flows were transferred to PICU, and then the last 2 days transferred back to 8 PA for 2 days and given antibiotic and then discharged. Birth history, born term at 38 weeks. Via emergency LSCS due to meconium aspiration syndrome. Birth weight is 3 kilograms. Antenatally uneventful. Postnatally was admitted for the meconium aspiration syndrome. Immunization is up to age. Sterile mental. Gross motor can balance with one leg. Dance to music. Fine motor. Draws a man with head trunk.
Any delay?
No.
Okay, skip.
Feeding. Breakfast usually eats bread, biscuits, formula milk. Lunch usually eats any meat or spaghetti. Dinner is rice with soup, carrot, broccoli. Snacks usually chips or ice cream. Doesn't like eating leafy vegetables or fruits. Social history, patient stays in Kinrara with mother and father. Mother is 32-year-old, works as an SN in BPUM, non-medical illness. Father is 36 years old, works as a PPK at BPUM, non-medical illness. Patient is Tom Chat.
Okay.
So upon examination today, just now when I saw the patient looked well, pain, not sublucate, not respiratory distress, good pulse volume, sanity less than 2 seconds, warm peripheries. He had rashes but improving in nature, mostly hyperpigmented with darkish in color of the abdomen, the trunk, the back, hands, legs, face, nothing. Edema is improving. Range of movement for upper limb was full, lower limb. Just now I tried to get him to extend his knee, he still was very irritable. What else? He didn't want to stand, but his mother said he can stand. Lungs clear. Serious breathing, no mama, and abdomen soft, non-tender. I couldn't palpate any lymph nodes. No new rash seen.
Okay, so based on your history of fever, rashes, cough, eye redness, joint pain, list me the possible differential diagnosis. Fever, rashes, eye redness, joint pain. What are the possible differential diagnosis? Kawasaki is one. Next.
Joint pain, rashes could be leptospirosis.
Okay, can. Some more. Dengue, can. Some more. Fever, rashes, joint pain, eye redness. What else could it be? Leg swelling, unable to walk some more. What are the common lower limb rashes? Cannot jalan. Pain some more. Common diagnosis in pediatrics. Have you seen any rashes at lower limb, bilaterally symmetrical, unable to walk, swelling? What is the diagnosis for that? Rashes not just lower limb, everywhere also, like him. Something we rashes is description in the diagnosis. Rashes ni description, how you describe the rashes? Macular, papular, apa lagi? What are the possible diagnosis, possible description that usually use when you describe rashes. So one of the diagnosis have that description. Purpura.
Hannah Schlangen
HSP, Inotion line, purpura. Okay, alright. Any viral illnesses can cause fever, eye redness. Any specific virus, fever, high grade fever, eye redness, rashes as well. What kind of virus do you know? Common virus that causing pneumonias.
Pneumonias. Viruses. RSV.
RSV, okay, some more. Other than RSV, ada viruses that commonly cause pneumonia?
Enterovirus.
Sorry?
Enterovirus.
Enterovirus. No. HFMD, yes, but not really. HFMD as a rashes, yes, can. But my question is, ada pneumonia that commonly cause all this pneumonia and rashes, high grade fevers? Okay, okay, fine. Except the enterovirus, what else? This one got injection one.
Parainfluenza virus.
Parainfluenza can, alright, but that one don't really explain why a patient got eye redness and all that. Influenza can or not? Can, but influenza also don't really have eye injection, but that's one virus can cause high grade fever with eye redness and with rashes, possible rashes as well. Start with A.
Adenovirus.
Yes, adenovirus. Okay, so that's one is one your possible differential. If you high grade fever, you have to think about adenovirus on top of the other differential. Yeah, Kawasaki, yes, leptospirosis possible, dengue, HSP. Okay, rashes, fever, cough, RNS. Okay, so one of the bacterial infection that will cause this fever and rashes as well. Strep can. Okay, ada bacteria that you know of that can cause target lesion, rashes. And this child is positive for it.
Mycoplasma.
Yes, mycoplasma. Okay, so mycoplasma infection can cause rashes, fever, even joint pain also. Okay, and pneumonia as well. Alright. Okay, so out of all these differential, what do you think is top on the list?
Kawasaki.
Why?
It's got rashes. It's got redness bilateral. You got joint pain. In the ED notes, they said he had cervical lymphadenopathy, so it kind of fulfills the criteria. He also had fever for 1 week.
Okay, so what are the criteria for Kawasaki disease?
Fever for 5 days. Cervical lymphadenopathy, bilateral non-purulent conjunctivitis, mucosal changes, so like strawberry tongue or fidget lips or red lips, rashes, polymorphous rashes that are non-vascular.
One more, is it?
Extreme movement of the extremities, so edema and
so this child has edema, right? Swelling of the lower limb and upper limb. Alright, okay, so okay, so that one is the typical classical features of Kawasaki's lah. What are the supporting features? On examination, you might find those features, but they are not part of the criteria. Especially in young children, they also can have what? What are the...
Irritability.
Yes, irritability one. Okay, so irritability indicate what?
Joint.
No.
Fever.
Not that, yeah, it can be because of fever, but specifically, it show inflammation where?
In the heart.
No. Kawasaki is an inflammatory disease, right?
Yeah.
Okay, it's a systemic inflammation. So inflammation don't occur in heart only. It occurs everywhere. So which part of the brain can have inflammation that causing irritability?
Meningitis.
Yes, your meninges lah. That's why if you do LP in Kawasaki patient, what result do you expect? Do you expect it grow anything? No, right? Because it will be aseptic meningitis lah. So that irritability is explainable by meningitis lah. Okay. On top of it, the high grade fever also. Alright, but the most likely explanation is the meningism lah. Okay, that's why they're very irritable, very irritable. Okay, alright. Some more, what are the supporting clinical features? Interesting. I'm not going to penalize you if you don't know lah.
Thrombocytosis.
Yes.
Lymphocytosis.
That one more of biochemical supporting diagnosis, supporting features. This one on clinical examination itself. What else can you see?
Perianal excoriation.
Yes, perianal excoriation. Alright, some more. What about the BCG?
Oh, BCG induration.
Yeah, BCG induration of flaring. Okay. So, can you explain why they have perianal excoriation? Think about one of the criteria. Which one do you think related to perianal excoriation?
The disformation of the.
No, it's not really. It's not about discrimination. So perianal consists of what region in terms of skin layers? It's your skin layer, which is your epithelium and all that. Then when during the transition into the anal region to the rectum, so your rectum consists of what layers? Same like your mouth. Same like your mouth. Same like your mouth, your tongue. We call it what? One of the criteria is called what? What changes?
Mucosal changes.
Yeah, mucosal changes. So your gut also is mucosa, right? Then you go to your anus, it's still mucosa. Then you transition into your skin layers lah. So that's why when you have inflammation of the mucosa, your perianum also can have very red. So erythematous. Okay. Now understand. Alright. Okay. What else? I think those are basically supporting features lah. Alright. So on top of it, because of his systemic inflammation, so what other organ can be involved other than your heart? Liver. So can liver can have what?
Elevated ALT levels.
Transaminases lah. So hepatitis features. Okay. So anything else in the liver? What are the structure in the liver? Or nearby the liver? Or next to the liver? Or inside the liver?
The gallbladder, no?
Sorry, gallbladder.
No.
What gonna happen to the gallbladder in Kawasaki? Think about inflame. When you have inflammation, gallbladder got swollen. So on top of it, you also got a lot of effusion inside. So it becomes like very swollen edema. So baby yang lahir detected very edematous. Then when they are born, we describe it as what? Very edematous baby. So huge. No, not microsomic. That one is just the size. If baby very edematous, internally detected, very large look edematous, very thick skin because of water accumulation. We describe the babies as what? Something with H, something fetalis.
Hydrops fetalis.
So hydrops fetalis just means baby very swollen. Okay, so if I ask you about hydrops fetalis, what are the common causes?
Inflamed gallbladder. So Kawasaki.
No. For newborn baby with hydrops fetalis, what do you think the cause? The common link? Thalassemia. What thalassemia?
Oh, beta thalassemia.
Not beta. Cannot be beta.
Beta? Alpha.
Alpha lah.
Oh, okay.
You have what? How many genes deleted?
Oh yeah, alpha. Yeah. What intermediate? It's gone there.
Yeah.
I know there's intermediate hydrops fetalis, and then there's one more.
So alpha thal got how many genes?
3 genes.
No, 4 genes.
4 genes.
So all 4 deleted, so you don't have any genes, then baby become hydrops lah. So those yang got 1 gene left, 3 gene deleted, and that one is a alpha thalassemia major or Budd's disease. Okay, alright. So hydrops is because of commonly caused by severe alpha thalassemia lah in utero. Your HB tak cukup, then heart failure, then become edematous lah. So hydrops basically describing the edema lah. So for gallbladder, how we want to describe that? With very swollen gallbladder. Hydrops gallbladder lah.
Oh, hydrops gallbladder.
Okay, so hydrops gallbladder basically very swollen edematous gallbladder due to the inflammation process of Kawasaki disease. Okay, so lung, any lung features? Inflammation lung?
Pleuritis? No.
Can. Anything's possible. Perfusion also can. But in the in the lung parenchyma itself, in the alveoli and all that, you will see some features lah, like viral pneumonia or ARDS features, due to inflammation. Okay, alright. So that's why some of them possibly take kidney as well, but not all of them lah. Okay. So for the heart, when you have heart inflammation, what are the signs?
The coronary artery vasculitis.
So vasculitis in the coronaries. Okay. For the heart itself,
Myocarditis.
myocarditis. So what are the features of myocarditis? How you diagnose myocarditis? If your heart failing, cannot pump properly, so how do they compensate? You cannot pump nicely, so you have to pump faster. So when you have pumping faster, what are the signs? Clinical sign that associated with tachycardia lah. That are the first sign. Always the first sign is tachycardia lah. Okay, then of course myocarditis.
Cardia, tachypnea.
So
Chest
okay,
pain.
depends on the age. Okay. If your heart not pumping properly, so cannot push the blood forward, some blood will also leaking to the back or regurg. So
Edema.
not really edema. So on examination, what do you detect? Especially on auscultation.
Fluid in the heart.
No.
Auscultation.
Auscultation on the heart. What do you hear? The regurg murmur lah. So you will hear the regurg murmur. So kalau got mitral regurg, may indicate left ventricle is not pumping properly. So what murmur you expect in mitral regurg? No, don't know. Systolic or systolic? Yeah, systolic murmur. Where?
Left.
Apex, tricuspid, pulmonary, aortic area. Think about mitral valve location. Which side? Left side, right side?
Left side.
So which one is nearby? LV or RV? In LV lah kan, mitral valve, right? So your apex nearby or not?
Yeah.
Yeah. So we at the apical region lah.
Okay.
Okay. So myocarditis features are those lah, tachycardia, all those chest pain possible, shortness of breath, tachypnea, and murmur as well. Okay. On ECG, you should probably see just sinus tachycardia. Maybe some LVH, RVH, depends on how bad it is lah. Okay. So just basically some of the possible features of Kawasaki's on top of your classical features, right? Okay, like if you don't know, I won't penalize you for it lah. At least you know the basic classical science. Okay, so investigation wise, what do you send?
ABC, CRP, ESR.
What do you want to see on ABC?
Anemia, thrombocytosis.
Thrombocytosis happen at first week or later?
First week, I think.
No.
Second week.
Second week, so
second week.
okay. So why do they develop thrombocytosis? Like it's a part of the inflammation process. Okay. Alright. Fine. Lepas tu, and then RP, LFT. Do you want to send?
Yeah.
So any expected result when you send those?
So ALT can be high.
Raise transaminases. Okay. RP? Nothing specific. Oh, got anything specific in the RP?
Albumin.
In LFT, yes, albumin. In severe disease, albumin will be very low lah in Kawasaki. Or any severe illnesses, doesn't matter. Pneumonias, whatever lah. Severe masuk ICU, you see albumin very low one. Albumin low indicate very severe illness lah. So same for Kawasaki. If you see the albumin level is very low, then you know like the inflammation is quite severe. Okay. On top with the transaminases as well. Maybe there's no cholestasis, maybe don't have lah. Maybe got, but most of the time don't have lah. Just transaminases. Probably because the inflammation is really not that bad, cause not bad enough to cause cholestasis. Alright. On the RP, nothing specific lah. Probably related to dehydration. If not drinking, no. You maybe got some risk urea, risk creatinine lah. But severe disease also we notice that some of them will have low sodium as well. Okay. Alright. And what else you want to send? CRP and ASR. What do you expect the result? Increase. Why do they increase?
Inflammation.
So inflammation lah. Okay. High CRP also can means what? Other than inflammation? Other than inflammation, what else can it erase? Why it erases for? You got infection? Can or not? CRP. Can CRP be erased in infection?
Yeah.
That's
So
the answer.
infection,
Okay. So high CRP means can be inflammation, can be infection. Okay. So this child, how high was the CRP?
I will see.
You never seen this patient before?
No.
Okay. Never mind, no need to check. It was 200 over lah. So it's very high. Okay. Alright. So what else you want to do? Any bedside investigation can you do?
ECG,
Do ECGs. Alright. What else?
chest X-ray,
Okay.
echo,
So what do you want to see on echo?
to see the dilatation of the.
Okay. So on top of the dilatation, what else do you want to see? Dilatation of coronary arteries, like myocarditis features. So can you repeat back what are the features?
Tachycardia, tachypnea, chest pain.
So on echo, what do you see? What did I ask about auscultation just now? That regurgitation.
Oh yeah, to see mama.
You cannot see mama.
Not see mama.
You see the mitral regurgitation
regurgitation.
lah. Because heart, and then you want to see the heart function as well. In myocarditis, your heart function is very poor. Maybe poor, maybe if not poor, is impaired. Okay. Then you can see also lah pericardial effusion, water collecting around the sac. Okay, seems like hydrops lah. Just water collecting. Alright. Okay. So how do you treat Kawasaki?
IVIG.
Okay. How many gram per kilo?
2 gram per kilo.
2 gram per kilo. So what does 2 gram per kilo indicate?
2 gram every 1 kilo.
No, like 2 gram per kilo means it's a high dose IVIG dose. Okay, that's why 2 grams mean. Low dose IVIG also got. If thrombocytopenia, for ITP, the dose will be lower lah. It won't be 2 gram, maybe 0.8 or 1 gram. Okay, so for IVIG specifically, you have to answer it's a high dose IVIG or 2 gram per kilo doses. Okay, if you don't answer, you just answer IVIG, probably won't get full mark lah. Okay, so IVIG you give, and then so any precaution when you want to give IVIG?
You can give periton before.
Does everyone need peritons?
No.
Okay, so why you want to do that?
To prevent the itchiness and like.
Okay, so the precaution is watching out for the symptoms. What else? What else precaution we take when we decide to give IVIG in patient?
We give aspirin.
No. If you want to give IVIG, how you want to monitor them? Can you give IVIG letak dia dekat belakang somewhere?
Put in acute.
Put in acute. So what else do you put on patient?
Put cardiac monitor.
Cardiac monitor. So what do you expect?
I want to make sure there's no tachycardia.
Okay.
Tachypnea.
Alright, then cardiac monitor also can detect what?
Heart ECG changes.
Any arrhythmias lah. Okay. Alright. Also you want to monitor the blood pressure as well. Okay, if any, what reaction? Any reaction? If severe something transfusion reaction lah. Severe reaction in transfusion is called what?
Hypersensitivity.
What is the term?
Type 1 hypersensitivity.
What is the term? What reaction? Something shock.
Septic shock.
Not septic. If you give something, they go into shock. If you give something dry, they're allergic to it. They go into what shock?
Oh, anaphylactic shock.
Yes, anaphylactic shock. Same also like IVIG. Okay. So next thing you want to give aspirin, right? So what about the aspirin dose?
3 separate doses.
It's not necessarily it's in a separate doses lah. However, the same also like high dose IVIG, aspirin also have different dose. So what are the two different doses? I don't have to give the number. So what are the high dose and low dose, right? So high dose is treatment for what? Low dose treatment for what?
High dose is for the Kawasaki.
So what is the term? To counter what?
Inflammation.
Yeah, anti-inflammatory dose. Those are the terms are anti-inflammatory dose. Then after that you change to what dose? The low dose is to counter what? What happened in second week just now?
The thrombocytosis.
So it's called what dose?
Antiplatelet?
Yes, antiplatelet dose. Okay. Do you know the doses? Don't know. Okay, antiplatelet dose? You don't know? Don't know. Okay, fine. Alright, can check there. Protocol lah. So usually anti-inflammatory dose is very high if we give in separate doses. Alright. Okay. So so when after you give IVIG for 10 hours, something like that, after that, what do you monitor after finish completed the IVIG?
The heart rate.
No. What are basically the main thing to say this patient is responsive to IVIG? What are the one thing we say? Hello. Assessment. We monitor what? In Kawasaki, what are the basically the very high one? Why do they come to the hospital?
High fever.
Fever lah. So after give IVIG, you want to monitor what?
The fever.
Monitor the fever lah. So okay lah. I don't want to ask IVIG resistant what it means lah. So usually how long we monitor after we give IVIG?
1 day.
1 day, 2 days lah. Specifically 36 hours. Okay. So if after 36 hours, if fever still persists,
And another dose of IVIG.
so it's called IVIG resistant lah. This patient IVIG resistant or IVIG responsive?
He took 2 doses.
Yeah, so resistant lah. After second dose, baru the fever settle. I mean, there is no spike after 6 hours, something like that. At the moment, still no fever lah. We don't know until tomorrow. If until tomorrow no fever, then like we can let him go back. Okay, so if let's say no fever for 2 days, okay, so what you want to do? Can go back. Okay, so antibiotic, the aspirin dose, you want to change? You want to keep the anti-inflammatory dose? You want to change to antiplatelet dose?
Antiplatelet.
Yeah, okay. Most of the hospital practice like that lah. 3-4 days no fever, they change to antiplatelet dose. Then you see back in the clinic. How long you want to see in clinic?
1 month.
Too long.
Too long.
Okay, so 2 weeks lah usually. Okay, so but it depends on the center. We practice, we keep the high dose until the appointment. If you go different places, the practice may vary, but does not mean it's wrong lah. Okay, so probably we keep the high dose until 2 weeks. After 2 weeks, we see back. Then maybe we change to antiplatelet dose lah after we review the bloods and all that. So in clinic, after 2 weeks, you want to see what you want to repeat.
IBC, RPE, LFT, chest.
No need everything lah. Most of the time we want to repeat the inflammatory markers. So what are the inflammatory markers we want to see?
IBC, WBC, CRP, ESR,
Okay lah. Alright. Then what else you want to repeat?
echo,
Echo. Other than echo, one more thing. ECG. So echo want to see what? Again?
the dilatation.
Yeah, the dilatation lah. This child got aneurysm or not?
Yeah.
Got aneurysm. Okay. So on ECG, what you want to see?
Whether the tachycardia is improving.
Other than tachycardia? Why patient on antiplatelet dose?
For inflammation.
It's antiplatelet already. It's not for inflammation. What do we want to prevent?
Blood clot.
Blood clot. So you got blood clot. What changes do you see on ECG? You've got thrombosis in coronaries. Think macam you punya MI. What happened?
Oh, ST elevation.
Yeah.
Okay.
You have to understand. That's basically the morbidity mortality cause in Kawasaki. Yeah, there is ischemic heart disease per se, but due to acquired problem lah. It's because of thrombosis. Adult one because of what? Ischemic heart disease.
That one is smoking.
Okay, they are more due to atherosclerosis. Then predispose patient to all those atherosclerotic plaque plus thrombosis as well lah. Okay, but in the end product is the same. You have ischemic heart disease lah. So you see the same changes lah. ST changes. Okay, so patient come with chest pain, Kawasaki history, must do ECG lah. Same. But the pathophysio is different lah. Okay, in Kawasaki, when you have inflammation, your intima layers also change. It's restructured over time. All this inflammatory process continues. In the end, the end product it become fibrosis, fibrotic scar tissue. So the layer is more of scar rather than the normal blood vessels punya surface layers. Okay, so when you have scar tissue, it's not very smooth. The blood flow also not very laminar, not very smooth. So you got very sometimes kind of distracted like longkang tersumbat. Those are this predisposed patient to the blood thrombosis. And the blood vessel remains the same until they're older.